morning, sir. I'll be presenting my case capsule. Myself, Dr. Jasmeet Singh from SDMH, Jaipur. So my patient Ashok Kumar is a 65-year-old male who is resident of Ajmer. He presented to us with the chief complaints of yellowish discoloration of eyes and sclera for past 4 months. Patient was apparently well 4 months back when he noticed the yellowish discoloration of eyes. Jaundice was progressive. It was associated with high colored urine, not associated with pruritus, but it was associated with clay colored stools, and there was no associated prodromal symptoms. Patient was evaluated for above mentioned complaints at a tertiary center in New Delhi with MRI, following which patient came to our hospital and underwent a percutaneous tube drainage procedure on 13th of November, following which the drain was draining yellow colored fluid of around 250 to 300 ml daily, after which his jaundice improved gradually and the tube was internalized. So now the patient has again been admitted for further management. During this course, there has been no history of hematemesis or melena. There's no history of any fever, no history of any lump in upper abdomen, no history of vomiting, no history of altered bowel habits. Patient has history of loss of appetite and loss of weight. Also, there is no history of any endoscopic interventions in this period. Past history. There's no history of biliary colic in the past. There's no history of jaundice in the past. No history of any surgeries and no history of any recent onset diabetes. Personal history. He has normal bowel and bladder habits. There's no issue of drug abuse. He consumes a vegetarian diet with occasional alcohol intake. Family history. No history of any malignancies in the family. So just to summarize, it's a 65-year-old male without any comorbidities, presented with the painless progressive jaundice associated with loss of weight and appetite, without any history suggestive of cholangitis, who underwent a percutaneous drainage, following which his symptoms improved and his tube was internalized.
So when you have a 64 or 5 years male presenting to you with these complaints, what all details one would like to have?
About the jaundice, whether it was a painful jaundice or a painless jaundice, the duration of jaundice, any associated symptoms with the jaundice, just to first to rule out whether it is a benign or a malignant jaundice.
So did you try? What are the things come to your mind when you are seeing a patient where there is a progressive jaundice of 4 months of this type the way you have presented?
The first thing I have to differentiate is whether it is a benign condition or a malignant condition. In 65-year-old male, it is most likely to be a malignant. Had it been a benign case, it would have been associated with some history of pain abdomen or a long history of waxing and weaning. A progressive jaundice in this age is most likely associated with a malignant cause, sir.
Sir, you mean to say that if there is pain, then but if there is no pain, if there is pain or if there is no pain, that decides about benign or malignant?
Not only the pain, but most of the time, most common cause of jaundice, benign cause of jaundice is CBD stones, and they usually present with intermittent pain, sir. Although pain can be present in malignant causes also.
So what is the complication of CA head of pancreas?
For CA head of pancreas, around 20, most of the patients of CA head of pancreas, they do present with the pain, but in this history, sir, the patient with a percutaneous drainage, it is unlikely for a patient with CA head of pancreas to undergo percutaneous drainage rather than endoscopic drainage.
So I'm not asking you to ask a differential. You said that most of the cases are benign will present with the pain. What are the common presentation of gallbladder cancer?
It usually presents with a pain which is due to biliary colic, which is due to underlying stones or due to liver infiltration. So that can also present with pain.
So the statement should not be so loose. Pain presentation, there are two malignancies. You only are telling that common presentation is the pain.
Yes.
You gave a statement. There is no pain. I will rule out benign disease.
No.
So the first thing that you think that it is a malignant cause.
Yes, sir.
It is a malignancy. What type of malignancy you are thinking about?
Sir, because first of all they drained it with the percutaneous method, so I am thinking block is at the level of hilum. So the two malignancies commonly cause.
Jasmeet, I'm not audible or what? Am I audible?
Yes, sir.
So first listen the question. First you answer, then you start giving explanations.
Okay, sir.
You get my point?
Yes, sir.
So what was my?
Sir, it was not audible, sir. Last.
What was my question?
Which is the malignancy that you are suspecting?
So
it's either a perihilar cholangiocarcinoma or a carcinoma gallbladder.
So perihilar carcinoma gallbladder. Why are you saying that?
So the voice is breaking. It is not audible.
Why are you saying that carcinoma gallbladder? Am I audible now?
Yes, sir. Yes, sir. Audible, sir.
So why are you saying that either carcinoma gallbladder or perihilar cholangiocarcinoma?
Because by suspecting the history, the block seems to be at the level of hilum, sir. It is not a distal block. Just
why?
Because if it had been a distal block, normally we don't put and stent or try to alleviate the jaundice without in the absence of cholangitis. If they have done it with the percutaneous drainage, the block is rather proximal than distal, sir.
To find out endoscopy was tried, or it was not.
Sorry, sir.
अनि के भन्छ त्यो साकेल आउँछ गाडीले अनि मुलाहरू
Can you please make your silent your mic? Somebody is AC. So because of only one thing, did you try to find out whether endoscopy was tried or not?
Yes, sir. I asked whether there was any history of endoscopic intervention or not, and patient said there's nothing, no endoscopic intervention was done, only percutaneous tube drainage was done.
Okay. So only because of only one thing you are saying that since suppose this patient doesn't come with the PTBD, then what would be your diagnosis?
Then I would include it, even periampullary carcinoma would be one of my differentials, sir, in that case.
What about perihilar cholangiocarcinoma in this patient?
Perihilar cholangiocarcinoma and periampullary carcinoma both would be a differential if patient does not come with the endoscopic drainage.
What about perihilar cholangiocarcinoma? What is odd in this patient about perihilar cholangiocarcinoma?
There's no history of any cholangitis. Patient does not have any fever. He only presented with jaundice.
Always present with the fever.
If you have any undrained systems are left, and then the patient usually presents with fever. Sir.
We are talking more of a philosophy. Have you seen perihilar cholangiocarcinoma? Any obstructed system should be having cholangitis. Then why not lower cholangiocarcinoma? Every malignancy should have cholangitis according to you.
Yes.
Yes, sir. Have you read or you are just giving your opinion? You are very surprising. You are giving statement after statement and having no base for that. Perihilar cholangiocarcinoma, do they present without pruritus?
Unlikely, sir.
You have only written no pruritus for 4 months. It's not about 1 month. 4 month patient has a history and there is no pruritus at all.
Sir.
Why do you think it's like that?
It might not have been a complete block, sir. It might be draining some bile.
Might not be a complete block. That is one of the answers. So perihilar cholangiocarcinoma, usually they have incomplete blockage.
No, sir. Usually they are complete block only.
So you have only one point to say that this is a perihilar because there is a tube in situ. What is your other diagnosis? In the same type where there is no tube has been placed and you get that patient first, then what would be your second diagnosis?
It could be, sir, periampullary carcinoma.
Periampullary carcinoma. Why are you saying that?
It is painless jaundice, sir. Usually in periampullary carcinoma, it is a painless jaundice. Although there is no history of any mucosal suggestive of any mucosal disease, but still it could be periampullary carcinoma.
Why are you saying there is no history suggestive of any mucosal disease? I don't understand this.
There is no suggestive of bleeding hematemesis or melena. Like so, as we see in duodenal adenocarcinoma, we see some sort of bleeding from the mucosa which could present as hematemesis or melena, which is absent in this case. So that is a point against it. But
present with hematemesis and melena.
Sorry, sir.
All duodenal cancer will present with hematemesis and melena.
Not all, sir.
What percent of the people will present with hematemesis and melena?
30 to 40% only.
Where have you read this?
I don't remember.
It's very. I'm not able to. I'm at loss. You are giving so many statements so confidently. It's very painfully difficult for me to come to any conclusion. So suppose you have go and proceed. You are thinking about carcinoma gallbladder and perihilar cholangiocarcinoma.
Yes, sir.
So why did you carcinoma gallbladder?
Sir, I couldn't hear the last line. The voice broke, sir.
Why did you think about carcinoma gallbladder?
In this case, sir.
Yes, okay. We are discussing.
Sir, we are not because I was suspecting a hilar block, sir, and there are two most common malignancies which cause hilar block. One was a perihilar and other was a carcinoma gallbladder. There are some points which are against carcinoma gallbladder. Like there is, yes, sir. Yes, sir.
Go ahead. I'm not.
Okay. There was like no history of any episode of biliary colic in the past. In Indian setting, we usually suspect gallstones in setting of carcinoma gallbladder. So that is the point which is against.
In India, what percent of carcinoma gallbladder would have stone disease associated?
So 75 to 80%.
Okay. Still 20% would have no stone.
No stones.
So uncommon problem of a common disease is more common than common problem of an uncommon disease. You understand? Last time only in GI clinics we discussed this type of thing. You get my point what I say?
Yes, sir.
don't have any other point to suggest that this might be a carcinoma gallbladder, because you are only thinking one diagnosis, that perihilar cholangiocarcinoma. According to you, if this type of case you get, you have clear cut one diagnosis, that perihilar cholangiocarcinoma. Am I right in saying this?
Yes, sir.
You don't have another diagnosis. You cannot entertain carcinoma gallbladder. You cannot entertain mid CVD cholangiocarcinoma. Based on the history, only you are entertaining one diagnosis, that perihilar cholangiocarcinoma.
No, sir, and carcinoma gallbladder also.
Carcinoma gallbladder, you said because there is
There is one point which is against it, but
Any other point which favors carcinoma gallbladder? How many hilar cholangiocarcinoma you see in your OPD?
less, sir.
Less
Not
means
that, it's not that common as compared to carcinoma gallbladder.
my question. Don't be philosophical. In your OPD, how many perihilar you see?
Exact number, I'm not sure, sir, but less than 2 to 3 a month only.
Three in a month perihilar you are seeing. Which center are you working?
Jaipur, sir,
By-
SDMH.
About 50 hilar cholangio per year.
In the OPD, sir, most of them are not operable. So
But still you are saying 30 to 42 patients in a year in a perihilar cholangiocarcinoma. So there should be a very high epidemic belt.
But-
We don't see that type of perihilar cholangiocarcinoma. How many carcinoma gallbladder with obstructive jaundice you see in Rajasthan?
these are also lesser, 2 to 3 only, sir, in a month. With jaundice, even less, sir. Hardly 1 or 2.
At your in Rajasthan, in your area, it means the carcinoma gallbladder with jaundice and perihilar incidence is same.
Very early, even lesser than jaundice, carcinoma gallbladder, sir.
But my dear, what you are telling, I am saying the same thing.
Yes,
You are telling that you see in a month, then you are for the carcinoma gallbladder, you are saying 2 to 3 units. We are saying in a month for this thing also. Both are okay. Let's go to examination.
The patient is conscious, cooperative, and well-oriented. BMI is 20. ECOG status is 1. There's no pallor, no icterus. Pulse is 78 per minute. The blood pressure is 134/84. Respiratory rate is 18 per minute. On abdominal examination, inspection umbilicus is central and inverted. All quadrants are moving correspondingly with respiration. There are no visible scars, sinuses, or engorged veins, but there was a dressing seen in the upper abdomen. Hernial orifice, no visible cuff impulse. Palpation is, it was no tender areas were palpated. Liver is palpable just below the right costal margin. The spleen was not palpable. Hernial sites are normal. The gallbladder was not palpable. Percussion. On liver dullness, it was felt in the fifth intercostal space. The liver span was around 14 centimeter in the mid-clavicular line. The flanks are tympanic. On auscultation, normal bowel sounds are heard. On doing a DRE, the sphincter tone was normal. The no palpable mass was seen, and the gloved finger was stained with yellow stools. Respiratory, CVS, and CNS examination were grossly normal.
So why you have go back to your examination? So what are the points in these type of patients where there is 4-month history of the loss of appetite, progressive jaundice, 4-month history? What type of nutrition you have seen assessed?
One with the BMI, other for nutritional status, we can.
35 BMI is associated with very good nutrition.
No, sir.
You have read any type of nutritional risk assessment?
Yes, sir. There are various scores available. Nutritional risk screening score we do. There is MUST score which is available. So
Follow your center. Any one of your scores are where BMI is one of the components?
MUST score, sir. MUST score includes BMI.
Every time BMI, what BMI you think is a good nutritional risk?
Between 20 to 25 is good, sir.
So suppose there is somebody 27 BMI, then what will you do?
He is overweight, but he is nutritionally preserved.
Is BMI a very good marker of the nutrition?
No, sir. No, sir.
Any other score, any other nutritional screening program, this thing you see, you follow in your ward, something which can be followed in the ward.
NRS scoring, nutritional risk screening scoring is also there, sir.
You tell what are the 1, 2, 3, these things we follow in the ward.
Sir,
Today, if you don't know about nutritional, this is very important component of the major surgery. There you are talking that hilar block is there, and you have to prepare the patient. This is the patient has come to you, and you have to prepare so that you could have a safe outcome. If you just see the radiology, see the history, and don't assess the risk and try to take care before operation, you are not going to have a good outcome. What is ECOG? 1?
European College of Cooperative Oncology scoring group is one is the patient where he can do his routine works without any
Just a minute. Please see the abbreviation. What did you say?
European Cooperative Oncology group.
What is the score 1?
There is mild restriction of his physical activities. Rest he can do his normal activities.
Which physical activity is restricted?
Like doing some rigorous works like working throughout the day, he's not able to do. He's now at his home for the last 4 months.
There are so many things available in the ward. We ask our residents, everybody does it. Do you do any one of them in the ward to your patients? Just bedside, simple test.
Mid-arm circumference.
What is subjective global assessment?
It has, sir, it is also a method of assessing. It has various components.
Yes, I know it is also a method of assessing. What are the components we use in this?
I'm not aware of some components in subjective global assessment.
So you should be aware of all this. You are MCC student now. You are not MS now. So you are only operating surgeon you want to be. Gallbladder is not palpable. Does it give you any clue or stereo diagnosis is very high or fast?
It tends
Please mute your mic.
अपर कैलिक्स में 8 mm है ना.
Dr. Vijay Kumar Agrawal, please mute your mic.
So it tends to go more in the favor of perihalar and tends to even rule out carcinoma gallbladder. In cases of carcinoma gallbladder, sometimes the mass may be palpable. Also,
on examination, please. Has it added to your differential? Are you able to come closer to your diagnosis, or still you are as it was in the history?
Able to come closer, sir. Rules out carcinoma gallbladder and even distal end blocks like periampullary and carcinoma hepatopancreatic tends to rule them out. Gallbladder should be palpable in those patients.
Carcinoma gallbladder you are ruled out just because gallbladder is not palpable. So what percent of distended gallbladder are palpable clinically?
Not sure of the exact percentage, but in a patient with a who has this PI,
you are presenting a case. You are making your diagnosis and you don't know the answer. How will you be sure? If you don't know that, what percent of gallbladder which is distended is palpable, and you are ruling out three diagnoses and you are only one finding, and you don't know the percent. Not acceptable, my dear. These blanket comments and all these things are not good for the senior resident to present a case. You have very objective that this percent of the people still there is a distended gallbladder. It can be palpable, so I may be wrong in this thing. No, you say that gallbladder is not palpable, so I just exclude that Garcia gallbladder is off. It means at your center you have seen the CT MRI and you want me to just say that let us see the CT MRI. That is what is the, so that discussion is of no use. If you just want to discuss CT MRI, then you can discuss in the radiology. Case presentation means the boy has a lateral thinking, how much he can think about somebody in a given scenario, and how he come to the closer to diagnosis. Not that you see the CT and MRI and come here and try to rule out left and right everything, and you want me to say very good, and then at the end you show me MRI, then you say right hepatectomy, finished. This is a MS level query that what percent of the distended gallbladder are palpable, not palpable. Gallbladder cancer, if gallbladder is not palpable, doesn't mean anything. Gallbladder at the neck, gallbladder is a thick wall gallbladder. Gallbladder may be thick wall gallbladder, it may be still cancer, encroaching the common bile duct. What are the different regions? The Rajasthan, North India, Rajasthan is not in the way of this thing, it is central India. So Rajasthan also has a high incidence of gallbladder cancer. You are not sitting in the south and west, where gallbladder cancer incidence is low. So we have to keep this gallbladder cancer in our mind. And this statement is absolutely not acceptable that since I am not able to palpate the gallbladder, I can rule out gallbladder cancer. So then you are giving one message to the examiner that you don't know what are the different causes of gallbladder cancer presenting with the jaundice. Very simple. Can you tell what are the different causes of gallbladder cancer presenting with the jaundice?
It could be because of direct infiltration of the right hepatic or the second, it could be because of any big nodal disease which is impinging upon the hilum, or it could be sometime due to a papillary type of a tumor which throws a thrombus into the CVD. That can cause it.
Very, very rare.
Or sometimes associated cholecystolithiasis in a patient of CA gallbladder can also present with jaundice.
gallbladder cancer will be associated with choledocholitis? What percent of CA gallbladder will be associated with choledocholitis?
Less than 10%. Sir.
On this point, you should have analyzed, writing on the paper that these may be the query. That's how you finish the case within 2 minutes, narrating only 2-3 things, and then coming to that patient came to this thing, PTVD was done. You have not given any respect to the history. Give respect to the history, analyze it properly. Then only you can come to the diagnosis. Gallbladder cancer, thick wall gallbladder cancer, thickened gallbladder cancer, which has multiple reasons to project obstructive jaundice, may not be palpable. Distended gallbladder may not be palpable. So this statement is not acceptable at MCH level. So what are you going to do? How will you start investigating this patient?
Sorry, sir.
How will you proceed now?
Okay.
You have
I will like to review the previous records which have undergone the investigation, the blood investigation.
No record, I accept. But what are the things you want to see? Which record first?
I would like to see the blood investigations report about the liver function test, the complete blood picture. And then
This patient has come to OPD and there is no record. How will you proceed?
okay, I would like to investigate the patient with some biochemical as well as radiological investigation at this moment of time to plan my further management.
Jasmeet, please see, I will do 1, 2, 3 this. I would like to investigate, then I would like to talk to them.
I would first need a chest X-ray and ultrasound whole abdomen.
What an ultrasound?
Sir, voice breaks.
Examination, what would you like to see? Ultrasound examination. What are the things you would like to see?
On ultrasound, sir? On ultrasound, sir? On ultrasound, I would first like to see about the liver status, whether there is any evidence of it is cholestatic or not. And then I would like to see if there is any intrahepatic metastases are available in the anywhere, and also if there is any gross ascites is seen. So I would like to look at these things too.
Only 2 things you want to see on ultrasound.
I would like to see the about the gallbladder as well, whether there are any stones in it or not, and what is the status of the gallbladder. Also, at the level of the block, I would like to confirm on ultrasound.
That's all.
And also for metastasis, gross metastasis can be picked up on ultrasound sometimes.
Why ultrasound investigation can tell you so many things. 1, 2, 3, 4. You are just trying to jump from here to there. There is a sequence to present. On ultrasound, I will see the liver, size of the liver, then echogenicity of the liver.
Yes, sir.
Then there is a you have put a PTBD might not be seen, but in a patient like this, then metastasis in the liver, any other lesion, then I could try to see the level of the blockage if possible. Then I would go to the gallbladder, see the gallbladder, how is wall, is there any associated stone or not. Then I can go down and see the lymph nodal status. Ultrasound can, then you can see can you see the vessels? You can add the Doppler and see the vessels.
Yes, sir.
No, not yes, sir. You should come from sequential manner. That these are the things I would like to see. Then only the person who is listening to you will feel good about that, and you can tell everything. You are jumping from here to there, and then only one thing you want to see on ultrasound. Ultrasound is such a beautiful investigation present everywhere. It can tell you, would you ultrasound multiple metastasis? Would you do anything more?
No, sir.
Very rarely people like to go to
The voice is breaking. Somebody's mic is on.
Okay, what is the next investigation you want to see? You want to do? Ultrasound. Can you show the ultrasound? Please show the ultrasound.
This is the report only available. It tells us the liver is enlarged. The echo texture is normal. There is bilobar IHB is present. The GB is shown to be over distended. There are slight edematous walls. Multiple calculi are seen in the GB, and also they have shown a mass in the lumen of CHD just beyond the confluence. Also, they have shown a periportal lymph node of around 2.2 into 1.9 centimeter in size.
Are you seeing whatever I said has been seen on ultrasound?
Yes, sir. Yes, sir.
You should learn to present in a proper manner. Your learning for you that how to present. And you could see that he has written gallbladder is over distended.
Yes, sir.
You are confident about gallbladder not palpable. So what did we see? I was not aware of this finding. Was I?
No, sir.
Then, so basic clinical methodology will be same, whether you are a consultant or you are a SR or you are a junior, it is not going to change. So if you follow word by word the basic methodology, then
ఓపెన్ పోస్ట్ లైక్ పోస్టివిటీ ఎక్కువ స్పేస్ ఉంటుంది కదా అక్కడ మొత్తం ఇట్లా స్టక్ అయిపోయింది అట్లా ట్రైవ్ పెట్టిన ఏం రావట్లేదు సో ఇమ్మీడియట్లీ హ్యాడ్ టు టేక్ దట్
is there somebody to mute this? Okay. So what is your impression now on ultrasound?
My impression is that the block is again at the level of hilum only, but the gallbladder is not showing any mass lesion. It is showing only stones. There is overdistension of the gallbladder is seen. There are intrahepatic biliary radical dilatation is also seen, and the echo texture of the liver is normal at this time, although there is liver is slightly enlarged.
Impression now. What is your impression now?
It is a hilar block, sir.
So why there is a stone in this?
In the gallbladder, sir.
Gallbladder is showing this thing. There is a edematous wall, multiple stones. Why there should be stones? You mean to say that God has been so unkind to him? So many things you said are getting wrong. You said that there is no stone, so I will not consider gallbladder cancer. You are saying that there is a stone. So what did I say? I said the common problem presenting with uncommon symptom is much more common and should be considered rather than uncommon thing presenting with the common symptom. This is a basic science. So my teacher used to say, think of the common things first, but keep an eye on the rare things also. So gallbladder cancer is commoner. Here you are saying stone. Why God is unkind, so unkind that he has given stone, and also gallbladder is distended. It means what? It means blockage is at least below the cystic duct, or it is a mucosine. Mucosine will be because of the stone or because of the even block. If there is a block as common hepatic, listen for your learning. I don't think you have been able to differentiate when there is we always say hilar blockage or the blockage hilar block either because of perihilar cholangioma or because of the hilar common carcinoma gallbladder. Carcinoma gallbladder also can involve common hepatic duct, and one of the differentiating feature, sometimes it's very difficult, one of the differentiating feature is the presence of stone. Presence of stone, and there is a sludge also. Sludge is a very poorly, so you have to be very, very careful in giving your statements, please. Remember. So you have to do more presentation. So don't enlarge periportal lymph nodes, all those things. These are the sign of the locally advanced disease. And already 4 months have passed. That may be the reason why these things are getting. What is the next investigation based on this you would like to do?
I like to do a CT whole abdomen, CCT whole abdomen with IV contrast, sir.
Okay. The reason behind?
This will help me clear the gallbladder status, whether there is any mass which is not seen on the ultrasound. We might pick it up on mucosal irregularities. We might pick it up on CT, sir. That would help us to confirm.
Okay. So what are the things which will be inadequately assessed on CT scan in this patient? And if you want to do a CT, you will do before this tube has been placed, or you would like to do before after tube placement?
Before tube placement.
So the tube makes so many things. Blood in the interpretation and in presentation. So there is also spleen is enlarged 16.6 centimeter.
So spleen is also, since it has been a long period of time, there might be development of secondary biliary cirrhosis. So we have to rule that out also.
Some have not shown anything. This is the only reason.
Sorry, sir.
Secondary biliary cirrhosis. What is the duration of the obstructive jaundice which can produce secondary biliary cirrhosis?
6 months. After 6 months, we can suspect.
In polydactylitis, in obstructive jaundice because of malignancy, and in obstructive jaundice because of the benign stricture. All are uniformly same. So please read it. It's not uniform, but it can still be there. Since you are finding this, but ultrasound has not shown any sign of cirrhosis of the liver. So it is very, very unusual for ultrasound not to pick up, because there have been seems to be good ultrasound. Soft tissue mass seen completely obliterating lumen of the common hepatic duct, common bile duct. common bile duct also has been involved. Means that tumor is going below the cystic duct also. It is answered so nicely. I feel it's a very good ultrasound. Confluence is partially forming. So it is more going in favor of the carcinoma gallbladder. What I said in the beginning, that Rajasthan is not coming in the area, but you are very much this thing. Have you got the CT scan? Let us see the CT scan, please.
Yes, sir. This is MRI. This is the CT scan.
Show the CT scan.
Okay, sir. So this is the 1 second, sir.
Go and tell me which phase you are seeing.
So this is the CT whole abdomen axial images. It is the arterial phase we have seen. We can see the bilateral grossly dilated IHPR. The liver is enlarged. The grossly distended gallbladder is seen, although mass lesion could be palpable. Even the spleen seems to be a bit enlarged, sir. I will come back. I'll come back slowly, sir.
Please go a little bit slow. You are running so fast.
I'll doing slow. So here it is. This is the left-sided IHBR. This is the right-sided IHBR. We could see their primary confluence.
So in a liver, it's very bad habit to talk about the confluence in arterial phase. It's always good.
Better seen in the
Arterial phase, you should discuss about arteries, which are relevant, which are important.
So this is arterial. This is the arterial. 1 second.
You said I am talking about arterial phase. You show the arteries, important arteries in that phase,
1 second.
rather than thinking IHBR.
This is the arterial phase. Here we can see the liver is enlarged, and this is the aorta, and these are the various arteries we can see.
Not various arteries. Various arteries means
I'll tell you. This seems to be left hepatic artery. Here's the junction. Even this. I need to slow it down, sir. I'm trying.
Where is the left? Show the artery.
I'll
You are
find.
just where is your point?
Just got the controls. These are the in the circus. We can see the arteries.
Yes.
This is.
Show me the artery. Show me the right hepatic artery. These are the arteries, nothing.
Yes, sir. This is the right hepatic artery.
Hey, why can't you put your cursor at this thing? This
I
is
have
the
to-
left hepatic. Okay, go to the portal vein. It's a wastage of time. You should go and read a CT scan more. Let's go to the portal vein.
This is the portal phase. Here we can see this seems the right hepatic system. This is the left ductal system, and here is the we're getting close to the confluence. This appears like a heterogeneous mass, sir. Just after the confluence of the biliary radicals, there is a cutoff seen. This looks like a mass, and this is the right hepatic artery, which is just abutting the mass, although there's some fatty.
You have to see the portal vein, main portal vein also. You have to see the in portal about right portal vein. You should tell about left portal vein.
Yes,
you
sir.
should talk about you should talk about the main portal vein.
This is
You have to
yes, sir. This the portal vein. This is the main portal vein, and the gallbladder here looks distended, and this is it looks there is no mass lesions is available in gallbladder.
please read the report. Please read report. We are running short of time now. We have 10 minutes more. I will discuss and finish it.
This is the CT report, sir. They tell that liver is enlarged, measuring 18 centimeter with bilobar IHBR dilatation, with evidence of heterogeneously enhancing complete obliteration of common hepatic duct, proximal CBD, with perilesional fat stenting, and associated mid and distal CBD appears to be collapsed. Multiple variable sizing enhancing lymph nodes in the periportal, peripancreatic, and pre-para-aortic region, largest measuring 1.4 centimeter at the right periportal region. The gallbladder appears distended without any wall thickness or evidence of any calculi. The rest is the kidney shows cortical cyst, and the prostate seems to be enlarged. So their impression is of complete obliteration of common hepatic duct, proximal CBD, with enhancing intraluminal soft tissue content with associated bilobar IH.
CT says there is no gallstone, but ultrasound says gallstone. What is your
CT does not sometimes is not able to pick up gallstones, or ultrasound is a better investigation to look for gallstone.
gallstone associated? Okay. So now
Yes, sir.
what you have to do?
I need an MRI to look for the proximal extent, sir.
Initially you said I don't need MR. Now you want MRI. Why?
No, we need MRI to look for the biliary extent, the proximal extent that is better assessed on MRI only, sir.
So then why not MRI in first go, everything on MR?
I wanted to look for vascular involvement also, that is better assessed on CT scan, sir, whether it was free from arterial or portal vein. And also,
Is it not possible to see the vessels on MR?
we can see at MR also, sir.
But most of the people do CT scan, but MR today, MRI angiography with the MRCP can tell you everything. But however, in our country, people are fond of doing CT scan again to see. So can we see the MR finding?
Yes, sir.
Please show the. I'm not interested in wasting time in going to the pictures because I have only 5 minutes left.
Okay. So MRCP is telling us about the common bile duct is normal in course and caliber in the mid and distal part with abrupt cut off of the CBD at the porta. With ill-defined altered signal intensity, soft tissue intensity lesion is seen at the porta region of 2.6 into 1.6 centimeter just distal to the primary confluence with resultant upstream biliary dilatation.
So here is what it is seen now. So if you see the MRCP picture.
Yes, sir.
So this is the classical site for gallbladder cancer also to compress to present, but still this is a very classical that gallbladder cancer is involving. But if there is if MR suggests what is MR calculi is there, 16 to 12 mm calculi is also there.
Yes, sir. This is
impression.
Sir, it is the block is at the CHD only. Yes, it could be either CA gallbladder, also neck, which is causing the same block, or it could be hierarchical angiocarcinoma. The final differentiation will be made only while patient is undergoing definitive surgery, sir.
So what are you going to do now?
I will do PET scan also, sir, to rule out any metastasis because of large lymph nodes which are seen. So it could be a metastatic disease also.
You want to do PET scan at this stage. So
I will
go up to differential. Which one of them PET is routinely done and in which PET is not done non-routine?
Gallbladder we do it routinely, sir. We are not doing it for hierarchical angiocarcinoma routinely.
So you have done PET scan also?
No, sir. We will do.
PET scan has not been done. So now what will you do?
I also need a CT volumetry, sir, if I am planning a definitive resection.
CT volumetry, why?
If it is a hierarchical angiocarcinoma and I have to do a major resection, we have to look at the future liver remnant. I need a CT volumetry also.
This patient, what type of resection do you think you are doing?
If
you
at all
are thinking only this thing, nothing else you want to see at this stage in the Jasmeet Singh ji. You want to do something more or you just want to think about surgery?
Oh, I can
do. You want to see coagulopathy?
Yes, sir, I'll do.
You want to see the listen, please listen. You are very fond of surgery because all the surgery agents think that give me the knife and I will cut anything. You want to prepare this patient.
Yes, sir.
What are the important things in a patient with obstructive jaundice in a proximal block?
Bilirubin level, sir.
You have not said I want to see the liver function. You have not told I want to see the kidney function. Does kidney matter in a obstructive jaundice patient?
Yes, sir.
How does it matter?
Patient tends to, it has to be.
You have read obstructive jaundice and kidney.
Yes, sir. Sorry.
Have you read obstructive jaundice and kidney?
Yes, sir.
What are the reasons for the deranged kidney function in a surgical obstructive jaundice?
It could be because of sepsis also, or cholangitis per se also, or it could be.
Don't guess, please.
Cholangitis can also derange renal function and decrease urine output.
What are the pathophysiology? I'm not asking you to give extend one more question. You said I have read obstructive jaundice and kidney. Had you said I have not read, I would say please go and read. Now you are saying I have read, but you are going to cholangitis. So there is no cholangitis. Obstructive jaundice will not do any harm to the kidney. My dear sir, please learn to say no if you don't know and try to note it down that I have to go today and day and night. Every day you are seeing obstructive jaundice. You cannot just be blank about the obstructive jaundice, how there is a problem in a kidney and you cannot prepare your patient properly if you don't know the pathophysiology. Very important. So you have not assessed coagulopathy, you have not tried to see what is the level of jaundice at present after the PTBD. You are not trying to see the PTBD, culture sensitivity. Is it patient is having some sort of sepsis going on, or it is sepsis free? You are not trying to see the nutrition. These are more important than going just liver volumetry, and I am going to resect right extended hepatectomy, so I want to see liver volumetry. First of all, the most important pillar of the liver surgery is proper preparation of the patient. Without proper preparation, you cannot save the life. You can cut anything you want, but you cannot save the life. So proper preparation is patient should be cholangitis free. Patient should be nutritionally properly nutritionally built up. Patient should be seen for his respiratory reserve, how much it is, how good is it, he can withstand this surgery. Does he require neoadjuvant therapy in a patient who has so much of lymph nodes are there? And what is the status of the liver is already under stress because of the jaundice. So we have to be very careful in preparing these patients. We cannot just go like this, and I think it's very, very important. It's a very important proper preparation. Then we always go and put and console and rotate pictures and see CT angio, portal vein, and arterial anatomy. You don't believe in pictures. We go and sit with our colleague and try to see rotate the films, take a proper picture, and then put in the rotive when we are going to operate this patient. So it's not about this thing. Would you like to do staging laparoscopy?
Yes, sir.
Right? So what I mean to say, it's very important at your level to think of the safety at every level. If patient goes home, then surgery is only good. You do everything and patient doesn't go home, then surgery is not good at all. So I think I will start at this level, and I am ready to take any query. Otherwise, I have to go to the OPD. So please, anyone wants to ask any question, or this thing. So I suggest you please read properly. Go to the radiologist, try to see the film, the console. So many information you go get on the console, and learn the preparing a obstructive jaundice patient for the surgery. Okay.
Thank you, sir. Sir, one of the concern of the student, how do we define the mid CBD cholangio?
So mid CBD cholangio, obviously it is below the cystic duct insertion normally, and it's now lots of literature is also available that if you can do a upper and a lower margin free resection, and then you can do a good lymphatic dissection as we do in gallbladder cancer and hyalocholangio. Usually it suffices, but it is the rarest of all the three. Either very high and low cholangio. The rarest one is mid-CBD cholangiocarcinoma. But for the patient, it is good because you don't need any pancreatic duodenectomy or liver resection, provided you have to do frozen of both upper and lower margin, because the intraregular spread of all these cholangios are very much well described.
Sir, in this patient is a history of 4 months and no jaundice is there. How do we explain this?
No, he said there is a PTB. Pruritus was not there. That may be because of the partial, and pruritus sometimes it is absent. But because there may be some little bit of partial block in the beginning. So total CBD might not have been blocked. That's why it's not blocked at the confluence. Block is little bit lower level. So maybe I still feel it is a gallbladder cancer. Encroaching from one side, you see the picture, it is not coming hourglass. It is from right side, it is encroaching. So here it may be slowly progressive, and that's why significant weight loss is also there. So much of lymph node is also there. Hyalocholangio usually by and large will not have so much of nodal preoperative load of the nodal disease, but it can still be there. So I will still think because of the site one, history one, and the way it has there is a stone disease associated, and blockage below the confluence at the common hepatic duct. So all these factors, they make it carcinoma gallbladder. But it can still be higher if you see, but it's very difficult to differentiate because histologically also the same, it will be adenocarcinoma only.
Yes, sir. So it is very difficult in case of mid CBD cholangio because of it's a cholangio or a CAGP naked infiltrating the CHD or CBD. In current scenario, we always think of it's a CAGP neck infiltrating into the CBD.
Yeah. One more important point is absence of the gallstone disease, usually. Because once there is a gallstone disease and it coming from North India, we should think about gallbladder related issue rather than thinking about de novo mid-colangio or even lower colangio. So, Dr. Jasmeet, there is sometimes there is a double malignancy also. It happened with me once. We operated a patient. We did a Whipple's pancreaticoduodenectomy for a lower block, and gallbladder came to be incidentally detected gallbladder cancer. And there is a block at the cholangiocarcinoma also. So I have not read anything in the literature. So we went ahead and did a chemo. After chemo, we did this thing also. Wedge of the liver we removed. Lymph nodes were already removed, but I don't know whether it is helped in the management or patient is surviving. That's all. So Anand, can we?
Okay, sir. Thank you, sir. We are closing the session.
Thank you.
Yes, sir. TD, sir. What?
Yes. No, I was saying any query.
Yes, sir. One question was asked. One of the aspirant on distal extent of the section. Probably we'll go further till down, just below the suprapancreatic. If the margin is positive, then we have to do the Whipple's probably.
Mid CVD cholangiocarcinoma, both margins has to be sent for fusion, upper and lower. Because as I said, intra submucosal spread of the. So it is very important to have a proximal margin, distal margin 3 once we are doing this. If any one of them is positive, then treatment has to be decided accordingly. Okay, Anand?
Yes, sir. Yes, sir. Okay, sir. Thank you, sir, for moderating today's session. Thank you.
Thank you.